Hello. Good morning, good afternoon, good night, wherever you're joining us. Welcome to our 12th site presentation, where we will be discussing NIRS and echocardiography in infants with congenital heart disease. It's a great honor for me to introduce my fellow citizen, Dr. Carolina Michel Macias. She studied neonatology and neonatal intensive care in Mexico and did her neonatal hemodynamics and clinical research program training at Montreal Children's Hospital. During her training, her research project was focused on NIRS in neonates with congenital heart disease in the preoperative period, and it's what we will be discussing. Then we have a fantastic panel with Dr. Gabriel Altit, who's an assistant professor in the Division of Neonatology at McGill University and staff neonatologist at Montreal Children's Hospital. He is the principal investigator of the Neocardio Lab and the program director of the Neonatal Hemodynamics Fellowship. His research interests are in neonatal hemodynamics and populations with congenital heart disease, congenital heart defects, congenital diaphragmatic hernia, pulmonary hypertension, and prematurity. We will also be joined by Dr. Valerie Chock, who's an associate professor for the Neonatal Prenatal Consultation Services and associate program director for Research Neonatology Fellowship at Lucille Packard Children's Hospital. She has expertise developing both clinical and research application for neonatal NIRS monitoring, including assessment of neonates with a PDA, preterm anemic infants, infants with HIE, and infants with congenital heart disease in the perioperative period. We will also be joined by Dr. Irina Prelipcean, who's an assistant professor of pediatrics at the University of Rochester and staff neonatologist at the University of Rochester Golisano Children's Hospital. Her area of academic interest is integrated monitoring and improvement of outcomes in critically ill neonates. She is training in TNE and developing her research in hemodynamics and biomarkers involved in the neonatal brain and adrenal dysfunction. And at the end, we will be joined by Dr. Tina Leone for Q&A. Thank you so much.
Thank you, Daniel, for your kind presentation. Should I start?
Yeah, go ahead. Thank you.
Okay, today I will talk about briefly about brain and renal injury in babies with congenital heart defects, NIRS and fractional tissue oxygen extraction in this population, and our research project, which is cerebral and renal saturation in neonates with congenital heart disease in the preoperative period. I have nothing to disclose. Medtronic support the Neocardio Lab. So for the plan of the presentation, as I mentioned, I will talk about a little bit on brain and renal injury, some principles of NIRS and fractional tissue oxygenation, and finally, a research project. So as we know, congenital heart disease is a common cause of childhood morbidity, occurring in 6 to 8 infants per 1,000 live births. And although most forms of congenital heart defects are now amenable to early surgical repair, deficits in impaired widespread neurodevelopment domains include fine motor skills, visuospatial skills, cognition, memory, and attention, and are identified in almost in a half of childhood survivors. In this figure, we appreciate that severity of congenital heart disease positively correlates with an increase of incidence in neurological impairment. So in the past 2 decades, there has been a dramatic shift in the focus from newly acquired brain injuries associated with corrective and palliative heart surgery to antenatal and preoperative factors governing the altered maturations of the brain and other organs in congenital heart disease. In this important study, it was described that newborns with TGA and single ventricle physiology abnormalities before undergo cardiac surgery sorry, I don't know what happened. There was evidence of brain abnormalities. It was evidenced by altered brain metabolism and microstructure shortly after birth. These impairments were widespread and did not confirm the pattern of brain injury that is typical of hypoxia, ischemia that was expected to find in this population. So the findings of lower ratios of N-acetyl aspartate 2 choline, higher average diffusivity, and lower white matter fractional anisotropy. All of these look more similar to the pattern of brain injury that is predominant in preterm infants. So this suggested that the abnormality of the cells associated with axons forming white matter tracts, such as the preoligodendrocytes, were the ones that were affected, such as in preterm babies. This is just to show that the finding of preoperative injury in different studies is frequent and includes white matter injury, stroke, and hemorrhage. The picture shows an extent white matter injury. So in this other study, total brain volumes of infants with and without congenital heart disease were measured using MRI to investigate if certain areas of the brain are at particular risk of disrupted growth. They found that babies with congenital heart disease have smaller brains, cerebrums, and cerebral brain matter. They included babies with TGA, aortic arch hypoplasia, and hypoplastic right heart. So other authors have previously found that there's also a smaller brain growth, but by doing measures longitudinally. And the mechanism of these findings remains unclear. They didn't found any abnormalities of placental overweight or fetal growth restrictions. So they hypothesized that tissue hypoxia may be a potential pathogenic factor. So, brain injury in congenital heart disease is complex and involves depletion of neural precursors, brain weight significantly smaller than those of normal counterpart, smaller brain growth, hemorrhagic and ischemic lesions, predominantly in white matter, and also abnormal brain microstructures and metabolism. So it is a really vulnerable brain in this population. In addition to structural abnormalities, there are also functional alterations that coexist in infants with congenital heart defects. Ultrasound studies in fetus have revealed that cerebral vascular resistance is altered in the presence of congenital heart disease. Also, we know that when significant structural disease exists within the heart, the intracirculatory patterns that result in preferential streaming of the most highly oxygenated fetal blood to the developing brain are altered. And while in healthy infants, cerebral diastolic velocities increase within the first month after birth due to closure of the PDA, this in several types of congenital heart disease, it must be flow across the PDA needs to be preserved. So this is just to show that duct-dependent circulation may result in unfavorable balance of systemic and pulmonary perfusion. And as we know, the ductal steal phenomenon may compromise perfusion to the brain and other organs. Here in the picture, we can see a retrograde flow in the descending aorta. So in this context of complexity of cerebral hemodynamics, neuromonitoring is key also in the pre-intervention period and is necessary for the development of neuroprotection strategies. NIRS can help us to recognize deterioration early, and taking appropriate action may yield to better outcomes. This is a recent study, and this study, 270 newborns with complex congenital heart disease, they made preoperative and postoperative brain MRIs and showed that the prevalence of postoperative white matter injury has declined, as we can see in the figure, whereas preoperative white matter injury rates remain constant. These findings outline that the perinatal and preoperative time periods continue to be high risk for newborns with congenital heart disease, and underscores the importance of investigation to identify risk factors and solutions to protect the vulnerable brain. Also, children with congenital heart disease have a number of risk factors for a potential development of chronic kidney disease later in life. Cyanotic nephropathy has been described in adults. So these factors include pathophysiological changes related to structurally abnormal heart and circulation, and also polycythemia, cyanosis, and chronic hypoxia, changes in renal blood flow and intraglomerular hemodynamics, and derangement in neurohormonal activations. In this study showed that the renal alterations exist already at the time of birth, with the observation that the kidneys of newborns with congenital heart disease are not reduced in size, or at least for left-sided obstructive pathologies that they studied, and it leads to renal enlargement, contrary to the hypothesis they had at the beginning of the study. And the nature of this increased tissue and its subsequent clinical significance is unknown and requires further investigation, but it just expresses how much we still don't know about the consequence of congenital heart disease in all the organs. So renal NIRS monitoring may help us to recognize compromise in renal circulation and limit injury in also another another vulnerable organ. This is a prospective study investigating preoperative cerebral and somatic NIRS in congenital congenital heart disease. The graphs show regional oxygen saturation trendings according to diagnosis, and regional oxygenation differed according to cardiac diagnosis. As we can see here, the different groups. So cerebral and saturation and renal saturation decreased gradually and significantly, and they differed according to cardiac diagnosis. And there was also a significant interaction between cardiac diagnosis and time. And so the cerebral saturation decreased significantly with time in group 3 and 4, which in this graph are the dose-dependent systemic and pulmonary and systemic circulation. So interestingly, they also reported some adverse events in 6 patients. Just to show here 2 of them. One of them was a recurrent paroxysmal supraventricular tachycardia, a seizure, 2 sepsis, 1 liver hematoma, and 1 suspected neck. And the patients with adverse events had abrupt changes in regional oxygenation during NIRS. Monitoring before, such as seizure, fever, and hematochezia, they described that almost 40 minutes before the event, with no other clinical context, the NIRS started to drop significantly. So this is very important, because it can alarm us very early about some derangement. So the NIRS provides us regional hemoglobin oxygenation status using a technique similar that the one we know of pulse oximetry. Both forms of monitoring take advantage of different absorption spectra between oxygenated and deoxygenated hemoglobin to the light of near infrared range. The primary contrast is between pulse oximetry is that NIRS. The data reported in pulse oximetry, hemoglobin oxygenation, and that data is only reported for pulsatile or arterialized sources, and the other ones, the non-pulsatile sources, are subtracted from the data output. In contrast to pulse oximetry, NIRS represents the regional oxygenated to total hemoglobin ratio of the combined arterial, capillary, and venous hemoglobin sources. So at any given time, the blood contained with an individual tissue segment exists in a distribution approximately to 20% arterial, 75% venous, and 5% capillary. So regional oxygen saturations reflect the oxygen extraction. Fractional tissue oxygen extraction reflects the relationship between oxygen delivery and consumption, and metabolic rate determines oxygen consumption and is different and specific between organs. This formula shows how fractional tissue oxygen extraction is obtained and reflects the percentage of oxygen removed from the circulation. So it's important to take into account all the factors that are gonna play in this balance, and how tightly hemoglobin holds onto oxygen, potentially limiting tissue oxygenation, is described by the hemoglobin dissociation curve. And for a given partial pressure of oxygen dissolved in plasma, as we can see in the image, and the curve gives an expected percentage of saturation of hemoglobin. And the shape of the curve shows a more rapid decline in a saturation once partial pressure of oxygen falls below 60 approximately, reflecting a tendency of the hemoglobin to give up oxygen to tissues more readily in an oxygen-poor state. So this describes the natural condition of many patients with congenital heart defects. So across their NICU stay and with different events, this curve can be shifting rightwards or leftwards accordingly. So in this very important study, the patients with congenital heart disease undergoing surgical intervention, the neonates were either TGA or HS, and were recruited for preoperative non-invasive optical monitoring of cerebral oxygen saturation, cerebral oxygen extraction fraction, and cerebral blood flow using diffuse optical spectroscopy and diffuse correlation spectroscopy. The major finding was that acquired postoperative PBL, white matter injury, in infants with congenital heart disease was highly correlated with longer time between birth and heart surgery. And the figure shows a box plot. A box plot of the volume or of new or worsened postoperative PBL for those patients with time to surgery of 4 days or less, and those with time to surgery of 5 days or more. So the explanation for the significance of time to surgery on the development of postoperative PBL is derived from the negative linear trend observed between the preoperative cerebral saturations and time. So interestingly, the authors found an increase in oxygen extraction, which could not be explained by a decrease in hemoglobin or arterial oxygen saturation. And furthermore, an increase in oxygen demand will be expected to cause a corresponding increase in oxygen delivery, but an increase in cerebral blood flow, which they also measured, was not observed, indicating a failure of compensatory mechanism. It was very interesting that they speculate that sustained decrease in cerebral vascular resistance during fetal life, which has been described for fetuses with TGA and hypoplastic left heart syndrome, could exhaust the compensatory mechanisms that are necessary needed to increase cerebral blood flow in response to a increasing oxygen extraction. So this is our study. Our study is titled Cerebral and Renal Saturations Progressively Decrease with Diastolic Stills in Neonates with Congenital Heart Defects in the pre-intervention period. This is a prospective study. Our group previously described that babies with congenital heart disease and diastolic still have adverse Doppler profile mainly in the anterior cerebral artery during the transitional period. So as I previously mentioned, NIRS estimate regional tissue oxygen saturation and reflex perfusion if the other factors are stable, the other factors that contribute to oxygen delivery, hemoglobin, and on assuming that metabolic rate stays the same. So there's limited that data on the behavior of regional saturations during the transitional period, as it has been more focused in the intra and postoperative period. So this is our research question. Our population is babies with congenital heart disease, which were admitted to the NICU with no major, no congenital abnormality, and we compared the babies with diastolic still in the postductal territory, and infants with absence of this diastolic still, and we saw the trendings of renal and cerebral SATs in the first week of life. So our objective was to describe these trendings, and we hypothesized that diastolic still will be associated with adverse cerebral and renal saturations. This is a single-center prospective study, recurring newborns warranting postnatal admission to the NICU. The infants were above 34 weeks of age with no congenital abnormalities or chromosomal defects, and they were monitored during the from enrollment to the day 7 of life, or intervention, whichever come first, and then all the data was averaged to have daily means. We also perform echocardiography every day until day 7 or discharge of intervention, and we look for retrograde flow in postductal aorta. And for this study, we use the last available echo of monitoring closest to day 7. We use descriptive statistics and also random mixed effect models to evaluate the trends. This is our population, is 49 patients. You can see there the different cardiac diagnosis that they have and the reason for exclusion that was mainly prematurity, but mainly trisomy 21. So we had 49 newborns, of which 55% had retrograde flow, and the median of monitoring was of 82 hours of life versus 76 years of life. And first, when evaluating raw data, we saw an association between retrograde flow and negative trends, both for renal and cerebral saturations. Demographics weren't different between the groups, only the retrograde group had more PG exposition. So we can see here the mean cerebral saturations per day we can appreciate that for the retrograde flow group, they are generally lower, and they also decrease every day for both groups. And the contrast estimate is of 8 points. We can see this is the entire cohort in the left. So we can see here how its cerebral saturation is decreased every day, and also described by previous studies by Lynch, for example. And in this, in the right, we can see the effect that retrograde flow has on the cerebral saturation. It provokes more drop in this cerebral saturation. So for renal saturation, we can appreciate the same. Retrograde flow has overall lower saturations, and they decrease with time, and more than expected, and that has been previously described for normal newborns. Again, this is renal sats over time for the entire cohort, and the effect of retrograde flow in these saturations. So to explore some associations between our parameters, first with time, we can see that renal sats, cerebral sats, and oxygen tissue extraction is gonna was decreasing. It's gonna interact with time, what means it's gonna decrease over time or increase in the case of this tissue extraction. So for the retrograde flow, we can see here and that it represents a drop. Sorry, not a drop. More extraction for the cerebral oxygen tissue extraction, and also cerebral sats and renal sats are gonna be lower in the retrograde group. And finally, just to explain this interaction for the renal sat, it means that the changes or the effect of the retrograde flow is going to be reinforced over time for the renal saturations. And for the cerebral saturation, we saw that in time there was a tendency to be lower by the end of day 7. Here we can see that in both groups that these are cerebral saturation both decrease, and we can see we previously mentioned which quantity they decreased. Preductal and postductal saturations, which were used to calculate oxygen extraction of brain and renal, respectively, were decreasing, but for the preductal, it was not significantly different over time, and for postductal saturation, it was significant over time. This decreased. These are the trends of renal and fractional tissue extraction in retrograde and non-retrograde flow. So we can see here that for the non-retrograde group, we see an steady oxygen extraction, and then this is our 100, which corresponds to 4 days of life, and also resembles what Lynch found if in time to surgery day 4. It increases significantly, whereas for the non-retrograde group, it doesn't increase. It remains constant. Sorry, in the setting of we have preductal. We have preductal saturations that remain constant, oxygen extraction that remain constant, but NIRS it's decreasing over time. So this could reflect an abnormality of flow, and also an incapacity of to match this decrease of flow. Also with in renal saturation for for retrograde group, we can see that it is progressively increases, and then by day 4 also it's not that notorious here, but also increases as it's according to the same. We have lower postductal saturation, so less delivery, more extraction, and less renal sat. But for the group with retrograde flow, we know that postductal saturation is decreasing over time, but we don't see here a compensatory mechanism of more extraction. But we do see a decrease in renal saturation. So this could reflect also that flow, if the other factors are constant, metabolic rate, hemoglobin, it could reflect that flow is decreasing. So I mentioned already our results. Tissue oxygen extraction increased significantly after day of life in the non-retrograde group and remained constant over time in the group with retrograde flow. And renal oxygen tissue extraction increased progressively over time in the non-retrograde group, whereas in the retrograde group, after a steady increase during first 72 hours, more or less, it remained constant. A random mixed effect model outlined that retrograde flow over time was significantly associated with lower cerebral tissue extraction and with interaction of time. So we know that that in babies with congenital heart disease, cerebral and renal saturation decrease progressively in the preoperative period, regardless of the presence or absence of diastolic steal from PDA. And this decrease is more profound in renal saturation of babies with ductal steal phenomenon. As PVR drops in the first weeks of life, diastolic steal increases, leading to overcirculation and systemic hypoperfusion. So ductal steal phenomenon may exacerbate an organ injury in babies with congenital heart disease. So retrograde flow in the descending aorta, we see this phenomenon that did not affect the fractional tissue oxygen extraction, possibly due to it can be low metabolic demand from the kidneys, allowing for a match of oxygen delivery, or an incapacity to increase oxygen extraction due to flow disturbances. Those with retrograde flow had also lower cerebral tissue extraction towards the end of day 7, possibly outlining maybe the same phenomenon, also a loss of autoregulation maybe, the incapacity to increase oxygen extraction with increasing metabolic demand due to flow disturbance when compared with those with retrograde flow. So as a conclusion, cerebral and renal saturations decrease in babies with congenital heart disease since birth in the preoperative period and really quickly, and time to surgery is important. Our cohort of congenital heart disease with aortic retrograde flow demonstrated significantly lower cerebral and renal saturations through time. And in retrograde flow in the descending aorta, the relationship between cerebral oxygen delivery and consumption is altered, possibly to alter blood flow distribution. This is why also it was very interesting to see in Lynch study that they also measure flow and they didn't see an increase in flow to compensate an increase in oxygen extraction. So preoperative period is a window of opportunity to limit brain injury and renal injury in this population, and NIRS for this is a very valuable tool. So for our project, eventually there's gonna be data extraction for this echo that were done daily. So so we can match the NIRS information, cerebral and somatic, with markers of perfusion by echocardiography. And future studies should investigate if NIRS values may be associated with brain injury profile, and eventually if intervention to have normal NIRS values could prevent this. So with that, I would like to thank the entire research team, as well as the contribution of the entire NICU to this research project of our neocardio lab. Thank you.
Thank you so much for that presentation. I want to just invite all of our audience to enter questions into both the chat and the Q&A, and that way we can have the panel address them. Let me just get started with a question that has already been posed, which is, do we suppose that the same results in cerebral and renal perfusion happen with pharmacological closure, specifically with indomethacin?
Well, in this population, I think it's a very different setting, because the PDA is needed in this case to maintain pulmonary or systemic perfusion. But the studies studying like NIRS after indomethacin have showed that there is a increase in cerebral NIRS after ductal closure, after pharmacological ductal closure. But in this case, we cannot like attempt to do that, because we are in congenital heart disease. We need this circulation. And we also for this situation we have PG exposure.
Right. Can you tell us a little more about the? You mentioned the different lesions that were represented. Can you share any other clinical correlations that you noted in these, two cohorts, and are there, and relatedly, what do you suppose are the clinical implications related to this?
Well, and in our study, we didn't separate or explore the results by cardiac diagnosis, only by the presence of retrograde or non-retrograde flow. But other studies, that the one that I showed, have shown that those babies with ductal dependent lesions have the lowest, like to start the first from where the first saturation was lower between groups. But I think for many, apart from that, I wouldn't know if there's like a difference between the groups.
Gabriel, do you want to add?
Yeah, I want to thank you, Carolina, for outlining the results. It's some fantastic work you did there. That was like a big project over 3 years. And I think for me, we decided to take retrograde flow on last echo as a marker that these patients were already over circulating. So it was a sense to us that there was already an imbalance between the pulmonary and the systemic resistances. And for us at the bedside, sometimes it's hard to say, well, at which point is it that this balance is, or this imbalance is so much of an issue that we need to either intervene, either by doing the surgery or the intervention, etc., or that we need to do certain manipulations at the bedside that may help to reestablish this balance. And the problem that we have is, how do we know that we've reestablished that balance, right? So I think that as we were adventuring in NIRS, this project had the idea of confirming first that, you know, NIRS would be able to be used as a surrogate to get a sense of what is happening at the level of this balance level. And so can we do interventions clinically at the bedside now that we have possibly an indirect measurement of this imbalance? Is there interventions that we could do to alter the PVR, alter the SVR, and potentially reestablish some of that balance? And would that eventually translate in better outcomes? Because a lot of the literature in the congenital heart defect population has focused on interventions that are neuroprotective during the operation or in the post-operative management. But there's a lot that happens in the, you know, these few days and even in fetal life. But, you know, it's harder to get control over what's happening in fetal life. But at least if we can have these like very critical moments of the fetal to neonatal transition, and if there's interventions we could do to preserve to some degree the cerebral blood flow at the expense of the overcirculation, then maybe we would be able to at least diminish part of the brain injury or part of the brain hypoperfusion that some of these infants may have, and which could contribute to their brain lesion. So I think it's interesting to see that the retrograde group compared to the non-retrograde group had different patterns. And one of the interesting things that I find, at least from these results, is that they also have different patterns of oxygen extraction when you compare them to their preductal saturations, right? So the cerebral oxygen extraction is different. And that might be a cumulative effect. That might be, you know, a compensatory effect, but it could also be a compensatory effect that's not matched to the need to what they have. So I would love to hear more discussion of the panel on this. You know, I can think of many interventions to support these patients when we detect certain thresholds. Like, do they need more transfusions? I don't know. I don't want to be to create iatrogenism either. Is it that they need an earlier surgery or earlier intervention? Is it that we need to find ways to alter PVR? So if some of these patients are on mechanical ventilation, are we, you know, ventilating them too much and then their CO2 are blown off, and then because of that we're over circulating? So it's all these kinds of questions that I think as a community of neonatologists and neonatal practitioners for these patients will need to kind of figure out clinically based on that. But that's more questions than an answer.
Yeah, just to follow that comment, and for the entire panel, from a pragmatic standpoint, now that you're managing these babies with NIRS, would you say that all of these babies were physiologically managed according to the NIRS reading? Like, because like we're used to the like safe boost sort of methodology. So, but I would love to hear what has been your consideration specifically for this population. How much of these values might be modified because you have expert physiologists like you managing them?
So at McGill, there's an algorithm about to use NIRS, but it was like for the population which is being monitored, you know, and is it low? Is it that dangerously low? Is it below 50? Take a look at this, like just the general algorithm and not specific for a cardiac population, which I think it will be like super interesting because to me, like knowing, okay, the cerebrovascular resistance and the coping mechanism to low flow are altered. So are these really a pathologic NIRS for this baby? Like it's so much to think about. But in this, the other important study outlining that they are different significantly in their saturations. As you say, Danny will tell us that for every cardiac diagnosis, the measures have to vary, no, to vary according to their physiology and not just the number.
And Daniel, I just wanted to answer. Oh, sorry. I just wanted to mention, we started the study and NIRS was not yet incorporated in our clinical flows at the Michel children. And it's at the end of the study that we released our clinical protocol. So this population of patients at the time, our teams had not been trained to use the NIRS, so to implement intervention. It's really like, because it takes years to implement a program. So during these 3 years, they were exposed to the actual readings, and there might be unconscious bias because people see the value and eventually they act on it. But the actual formal clinical protocol that we have implemented has been implemented when actually Carolina has arrived. And at that time, we had already finished the recruitment. So hopefully that answers your question. So maybe there is an element of, reacting to values, in the sense that our team were not blinded to the values of the monitors. They were actually exposed to the values of the monitors, but there was no implementation of clinical pathways based on this value at the time. Now we have a clinical protocol that Carolina outlined, which really targets the extremes, so less than 50 or more than 85.
I just wanted to add that it's interesting. I mean, I think thresholds are important, but also like time under those thresholds. So kind of establishing between the cerebral and the somatic NIRS. And the other point that I wanted to bring up and discuss is in general, the somatic ones are they're a lot, they vary a lot more, even in general in babies, and then specifically in the children that have congenital heart disease. So if you've considered looking at the somatic cerebral difference, that's been published before, and if you have, it's not just the steel, but if you have states of like low cardiac output, the redistributions to sort of account for that redistribution and the sparing of the cerebral circulation.
Well, with regard several renal sets, just to see like the cohort, you can see that they are it's very small already. No, it may be just 10%, and that has been reported like this is shock, like this is a low cardiac output. But we are not, we didn't use the ratios in our study. Maybe we can do it, I don't know, but I have seen in another cohorts of these babies that they use this ratio of 10, but it's also not that well established. And also in other cohorts, it's already switched, which is very weird. Like cerebral is all the time higher than renal, so it's how to interpret that. I don't know. I think there's a lot of many things to see and investigate there. But yeah, certainly for our group, the cerebral, the ratios are low.
Valerie, oh, go ahead.
I'm sorry, I was just going to add, well, first of all, Carolina, this is a really great study, so congrats on putting it all together. I think getting back to Tina's original question too about, what type of congenital heart disease this might be, I think plays a huge, role in these results. I think Gabriel knows we published earlier right versus left-sided congenital heart disease lesions and how that can impact your cerebral versus your renal NIRS values. Because if you think about it, how much of that is an impact of flow versus oxygenation to begin with, and what has the greater impact on the NIRS values. So I think those are some important characteristics to, as you go forward, you might want to track. Similarly, I think it's great that you guys are going to be getting routine echo studies in this population so that you can look specifically at blood flow patterns. I would also say, are you going to look at like anterior cerebral artery blood flow? I think it would be great to actually see what's going on directly in the brain and correlating that with the retrograde flow dynamics. And then lastly, I think we all have to be cautious, knowing Safe Boost's findings, that is a completely different population, the preemies. So, is 55 to 85% really even relevant for congenital heart disease, right? Do we need to lower that threshold? And I think we have to be very cautious as we all start thinking about, like, are the interventions for these lower thresholds appropriate, as you guys are talking about. So it's kind of a wide open field right now. I just want to make sure everyone is cognizant that we can't transpose what we're thinking about for the preemies directly to these kids with congenital heart disease.
Great points. There was also a question that was brought up about how delayed cord clamping changes in babies with congenital heart disease versus not. And Gabriel, I want to have you answer that.
It's an excellent question. I think I want to mention we're still at the phase, Carolina tackled a lot of the data collection for everything that's NIRS related. She also mentioned we did echo every days for these patients that are full anatomical, fully functional. And so we're at the stage of extracting 2D, 3D volumes, MDAM, outputs, measurements in the systemic circulation, evaluation of the ductal size, evaluation of shunts. So we collected a lot of like clinical information too, like PGE on a daily basis, the medications they were on, the hemoglobin, the creat, the urine output at the time of the echo, all these things. So pH, CO2, blah, blah, blah. So obviously there's going to be a lot of data to kind of put together to try to better understand these signals. And one of them is that we do get anterior cerebral artery Dopplers at every single scan. So we'll have like the trends of that in relationship to the cerebral NIRS. So I'll get back to that point, Valerie, as soon as I have the answer for you. For the delayed cord clamping, we do it like routinely at our center for all congenital heart defect patients. The only patients in which we don't do a delayed cord clamping is actually when patients have DTGA and will need urgent septostomy, and that upon delivery, during the delayed cord clamping, we sense that the baby is not tolerating it, basically. But if not, we try to do it for everyone. We did collect the information of how much timing before the clamp happened. So is it 30 seconds, 35 seconds, 40 seconds, 60 seconds, etc. So we'll be able to get more information on that. My concern is that I think that more than 90% of our cohort probably had about 1 minute of delayed cord clamping. So it's going to be a bit more difficult to actually outline who of them or the impact of it. And there's a bias. You obviously, there's the bias of the physician who's in the delivery room, who sees that DTGA, who's been told this is an intact septum, and there's an entire, cath lab in your NICU ready to do a septostomy. They usually will clamp earlier rather than later, to be honest. And these are the babies who are typically more hypoxic in the first hour. And often during that time, we didn't have the NIRS on for, matter of urgency. So we won't have necessarily that data. That's going to be data missing. But I do think that, in neonatology, we're getting towards more and more understanding that, this is a very important factor in the hemodynamics of these patients, the delayed cord clamping and handling of the cord. So definitely, I think that eventually a follow-up study, because I know that many centers don't do delayed cord clamping for some of these congenital heart patients. So I think it's going to be I know there's, I think, an RCT going on it right now. So it's going to be an interesting thing. And if we can eventually bring NIRS to better understanding their oxygenation, that would be great. And I see Carolina has her hands on.
Yes, just wanted to comment on the delayed cord clamping, because in the study of Korea, with shows the different SATs, they are pretty like lower to 2 hours in like just generally speaking, are 40s, even 50s, and then maybe this is some of the factors that contribute to overall a higher saturation than expected for these babies in the first day of life, for example, about 70s.
And also the impact of increased fetal hemoglobin from delayed cord clamping, I think, is something that we're still exploring as well. So it's a lot of factors in play.
And, relative to your comment, Valerie, I do agree that CHD population we shouldn't necessarily translate results from the premature population to the CHD population, first of all, because of their maturity level, but also because of their inherent changes in physiology. Their cardiac performance, their flow, the way their PVR and SVR are probably not behaving exactly the same way. The fragility of their vessels are different between the two populations, like regarding IVH and bleed and things like that. This is not the typical brain lesions we see in CHD patients. So they most likely have similar patterns, but they also have very different patterns of injury mechanisms. So we have to be precise and we have to be cognizant of this when we actually analyze. There's actually, and what stemmed the reason why we implemented a clinical protocol locally is that one of the patients during the study was found to have passed away sadly from a sepsis. And the clinician at the bedside had picked up that the renal SAT and the cerebral SAT were well below 50 for a few hours before the actual septic event. And so it came back that, you know, we have these monitors, we're monitoring these patients, and this patient had low value. Had someone kind of triggered a mechanism, would we have basically intervened earlier and this patient would have, you know, survived potentially. Now, I'm not saying NIRS is a sepsis monitor, right? It's not that I'm saying. What I'm saying is that if you do implement NIRS in your unit, it's to take the whole picture of the patient into consideration. And that's what we decided to do and implement as a clinical protocol after that, because of some of these events. We also picked up a baby who had PGE for a coarctation. The PGE were stopped because the feeling was that the baby did not have a coarctation. And eventually the renal saturation, cerebral saturation changed dramatically. And the clinical team decided to restart PG overnight just based on that. And eventually the patient had to go emergently to the OR the next day because it was true quark. So it's kind of, you know, like when you implement these technologies, I think a key element is how do you train your teams to integrate the information at bedside? And there's a lot of integration. It's a bit like how do you train teams to like read the heart rate monitor or your saturation trends, right? It's put all these trends into the context of, you know, the clinical physiology and what's happening at the bedside of these patients.
I think also it's really important to remember that studying what is the right way to use them is really important. And, you know, what you're doing is really valuable in trying to identify patterns and, you know, and understand which are the babies who, you know, may need different interventions. And so I applaud you for both, you know, using the tool, but also trying to study it and learn more about how we should use it properly. So I think, you know, this is an early step in really learning how to use it well, but I think, you know, you're doing a great job in trying to methodically look at it. With that, I will turn it back to Daniel.
Yeah, so we remind you to please complete the session evaluation. Here you have a QR code where you can access it. And again, to invite you to the Regan Giesinger Clinical Cardiopulmonary Physiology for Care of the Sick Newborn course, which will be held in October 20 to 21, 2023. There you can also see the QR code. And I don't know if you have any final thoughts. It has been an amazing session.
Thank you, Carolina, for presenting our results and your result, and thank you for the hard work. I know you spent many, many hours analyzing the NIRS signal, so thank you. Thanks to the panelists for your great ideas.
Thanks to both of you for being here and sharing your work with us.
Yeah, thank you so much.
Thank you.
Gracias.
Gracias.
Bye.